This meeting is being recorded. Hello, good afternoon. Hello, hello.
हाँ सर, गुड आफ्टरनून।
Good afternoon, sir.
सर स्टार्ट कर सकते हैं सर आप।
Start कर दें?
जी जी जी, 3 बज गया है सर।
यही लो ना? Yeah. Is it visible to you, sir? Hello?
सर नॉट विजुअल सर।
Visible तो कैसे नहीं होगा?
हाँ गुड आफ्टरनून, अभी है सर।
है? एक सेकंड इससे शेयर से होगा ना? स्क्रीन और शेयर साउंड लेआउट। ठीक है, अब आ रहा है?
नहीं सर, नहीं आ रहा है सर।
अरे ये शेयर तो कर लिया ना? अब आ रहा है?
हाँ सर, अब आ रहा है सर। मेरे और एक सब है मेरा।
Is it okay?
इट इज
Hello?
ओके, इट इज ओके सर।
So, dear friends, this side Dr. Pradyum Sharma, and as per the course direction by API is that there's a short course for postgraduate and junior residence teaching program 2025 and 6. My sincere regards to Dr. Jyotirmay Paul, who is a president API, Dr. Kamlesh Tiwari, Dean ICP, Dr. Gideshi Mathur, who is a Dean-elect ICP, Dr. Agam Bora, very dynamic personality, Honorary Secretary API, and the course director, Dr. Puneet Saxena, is a wonderful personality. He's a senior professor, unit head at Medicine Medical College. So the topic today is a guideline-based management of type 2 diabetes. Now, as you all see, that this is a wheel. This is a circular picture is a wheel. It is RSSDI wheel. Because to start with, initially we thought that diabetes is only is a glucose disorder. There's a hyperglycemia or there's an increase in blood sugar levels which passes through urine and give rise a lot of complications. So a couple of the drugs did come like insulin and the sulfonylurea, which lower down the glucose levels. Patient did improve, but not to a great extent improve. And later on came to know that many of the comorbidities are there. So people kept on dying because of heart failure, coronary incidents, the renal failure, liver involvement. So what we call is a cardio-renal metabolic disorder. I saw the early incidents of brain attacks or stroke. So as all we know that the three types significantly main diabetes type 1, which is primarily almost less 10% or little less than incidence, which is primarily because of the autoimmune disorders or genetic variation. There's insulin deficient diabetes, has to be managed through insulin only. Now then we have a type 2 diabetes, which is primarily is a later onset in adults, though in today's scenario in South Asian, it is having a little early onset, almost 10 years before than Caucasians, and associated with obesity, an active lifestyle, hereditary, which are the primary leading cause. The main pathophysiology, there is a high insulin resistance. So what is the difference? As what we know, type 1 and type 2 diabetes, which is a sudden type 1, suddenly just patient gets polyuria, polydipsia, patient loses weight. But type 2 diabetes is a gradual onset, generally in children, then in adults. They're low BMI, almost less than 20 or 21 BMI. They're thin, normal, while in type 2, they are generally obese people. Then ketosis is pretty common type 1 diabetes, which is rarely seen in type 2 diabetes, but though do have presence. Autoantibodies are always present in type 1 diabetes. And there's endogenous insulin, which is almost lacking in type 1. So to start with pathophysiology, it was initially thought that it was this ominous octet. And there were eight pathophysiological defects. And for years and decades, we have been taught this, there are the eight defects. As we are evolving day and day, now there is a learning. Now we have seen more than eight, then 10, then 12, and now we can have as a dirty dozens. So in dirty dozens, we see that the causes of the diabetes leading to type 2 diabetes primarily is a beta cell failure, which has a low beta cell mass, and there's a low beta cell function. So what happens? There's a mass is low, and whatever the beta cells are there, there's a de-differentiation from progenitor cells to beta cells, which secrete insulin is low, and they are exhausted much earlier, and there's a dysfunctional. And then there's associated with the high adipose tissue, we have a more intravisceral fat, intraorgan fat, and the skull, we are more little sarcopenic, which is considered as a Caucasians. Our muscle mass is less than what the people in the Caucasians are there. Again, the liver gets involvement earlier. There's a which are primarily all resulting in high insulin resistance. Then there's a pancreatic amylin deposits are there, and then again, coming to the brain, there is a dysregulation at the brain. Impaired appetite regulation is disturbed, which increases sympathetic tone, and there's a decreased dopamine activity. And we come to the GI effect. There's an incretin effect is low. Then Caucasians, we have a low incretin effect, and there's a high inflammation rate. And then again, there's an immune dysregulation in the system. And again, coming to the stomach, there's a stomach, the gastric emptying is abnormal. There's a gut dysbiosis, and there is an increased glucose absorption. And coming to the glucagon level, there's a high glucagon. The South Asian people have a high glucagon levels compared to Caucasians. And at the kidney, there's a high incidence of glucose reabsorption where SGLT2 works by increasing the glucose release from the kidneys. As we all understand, the incidence is almost gradual increase in the last 30 years or 3 decades, and every 11th person is a diabetic. And what we call as a diabetes study says almost 101 million people are diabetic, and there are 135 million pre-diabetics. But if we take a total load, the 135, 101 is a 236 million people are diabetic. As a pre-diabetics in the coming years, if not managed well, not being looked after well, and not being managed obesity, they are likely to be as a glycemic burden to the people. And if we compare with India is almost a capital, second to China. In China, there's 135 million people are diabetic, and pre-diabetes almost 170 million people diabetes are in China. But here we have a better regulation, better management of diabetes than compared to China's. And we see that what the diagnostic criteria, how we decide what could be a diabetes or the pre-diabetes. If A1C is below 5.6, fasting is less than 100, and then postprandial it is less than 140 or 139. And in pre-diabetes, it is 5.7 to 6.4, and the fasting is between 100 to 126, and post OTT is 140 to 200 or 199, grossly 199. And in diabetes, it is 6.5 above. Or fasting is more than 126, or the post glucose challenge is more than 200. This is a news couple of days before. The 1st May 2025, the business standard came with a surprising data. And Dr. Shashank, a few months before, also said in Times of India, it is not 11% rise. It is a 20% jump in last 1 decade. 20% jump. But this business standard, which just on the 1st May, there's a 50% surge in diabetes in individuals under 40 years age. It was previously taken as a 50 years, but now the age has been shifted from by 10 years, from 50 to 40. And there's a 50% surge in type 2 diabetes. And the red flag sign, what the red flag sign, there's been 50% jump in prevalence of diabetes among individuals under 40 in recent years. And speaking of the recent health in hosted by Practo, the prevalence of diabetes 11% all across India. And for the prevalence of type 2 diabetes has surged among young individuals under 35, not even 40, it is under 35, experiencing a 50% increase in incidence from 2002 to 2016. In just that time, there's a 50% jump. And the main points are that the number of the people living with the diabetes is rose from 200 million, which was in 1990, 830 million. Normally, the data says that 700 million in 2035, but it is 830 million in 2022. The prevalence has been rising more rapidly in low and middle income countries than high income countries, which was initially said that diabetes is a disease of rich people, high upper class. But now we are observing now it is a low middle class getting high impact of diabetes. And more than half of the people living with diabetes did not take medication before the diabetes. And now we know that life expectancy is cut down by 16 to 12 years. A normal life is a person is having diabetes and associated having comorbidities has been shortened by 10 to 14 years. Number one. Number two, in the last decade, last 10 years of their life, the patient runs from pillar to the post, means from house to hospital, hospital back to house, hospital. Having many of the comorbidities, having a renal failure, chronic renal disease, having a heart failure, looking for many of the heart medication support for heart failure, and then having coronary incidents, a high incidence of coronary strokes in people. And there's an early, 10 years earlier, the South Asian population getting as 10 years early cardiac stroke, cardiac coronary incidences. These are micro and macrovascular complications, and there's a diabetic retinopathy, nephropathy, and there's a neuropathy, and then the macrovascular complication, as what I told you, is the heart attacks are there, early heart disease, and we have a bad type of plaque formation. We have a high calcium plaque, number one. Number two, the coronaries are smaller than the Caucasians. Number three, our lipid deposition is overall in coronaries, not like what has been seen is segmental in Caucasians. We have poor coronaries, we have a small coronaries, and the plaque formation is bad. It is a universally long coronaries are affected, and besides, there's high ketchup score. There's a bad plaque, and we see the strokes. We have again high incidence of CV strokes. Peripheral vascular disease is again common, but peripheral vascular disease is more common in Caucasians. In South Asian, we have a low peripheral artery disease, but definitely neuropathy is higher in South Asian population. So now, if we see the ADA or ESC guidelines for managing type 2 diabetes, is what been shown here in the picture. Then we used to start, the guidelines says start with one drug, observe for 3 months, add two drugs, observe for 3 months, then start with three drugs. And what the first drug of choice is a metformin, which is a good efficacious drug, and the hypoglycemia is pretty low. Weight neutral, it is a weight neutral, and side effects are there, just lactic acidosis, though that in practical clinical medicine, we don't see that much of lactic acidosis. And wait for 3 months. And if you don't find the response, you don't find the target values A1C, you can add sulfonylureas, you can add glitazones or DB4 or GLP-1 or insulin. In sulfonylurea, they're very effective, very efficacious. And the first generation of sulfonylurea provide the very long acting, but the hypoglycemia was very bad. For 3 days or 2 days, for 2 or 3 days, hypoglycemia continues to be there. Most potent hypoglycemia from insulin and sulfonylurea, most potent hypoglycemia occurs. So, especially in the first generations of India, they were pretty bad drugs. Hypoglycemia, and many of the people have died because of hypoglycemia if not been observed over a period of 3 or 4 days time. So they are very potent. Hypoglycemia is moderate risk, and then the weight gain is there because the person shows he's going hypo, and he or she keeps eating more and more, and there's a definite weight gain. With glitazons, the efficacy is good, hypoglycemia is pretty low, but weight gain is there. And if there is increase in heart failure incidences, increase in sodium retention, and there's an increased chances of fractures are also been reported within the high dose of glitazons. And they have been said that it may increase chances of total loading dose when it's more than certain values at bladder cancer. And there was a time that procyclidazone was stopped being from the market again, but it has come back. So Rosie was lost its clinical values because there was a high incidence of bladder cancer with rosiglitazone use. Then DIM4 inhibitors are beautiful drugs. They stop beta cell apoptosis. They are better working at the beta cells also, but efficacious are not very strong. But hypos are very low, and weight gain is almost neutral. Coming with now GLP-1, which is the RAs in agonist, they are very potent, very strong, especially hypos are not that much. They have a low risk hypos, and significant is primarily they have very high effect on weight. And with the recent new latest molecule, tirzepatide, which has come, or Wegovy has come up, and semaglutide injectables, there's a significant weight loss at 18 weeks trial. Then insulin, lovely, beautiful, but is hypos are there is very efficacious, very strong, highest efficacious, but hypoglycemia is pretty high. Then if you don't find for 3 months, then you can add another third drug, and later on insulin. But here today the system is changed. We are not following its guidelines. It why the South Asian population is different than Caucasians. We have certain observation. My observation that I've done a little research work in last few days, and there was a diabetes care in 2023, the Masala study. The Masala study is a mediators of atherosclerosis in South Asian living in America. Masala study 2010. The South Asian population has higher prevalence, early age, onset of type 2 diabetes, that is almost 10 years before than counterparts of Caucasians, and the atherosclerotic cardiovascular disease is much again high, and almost it is said to be a decade before. The South Asian Americans in the Masala study had a higher type 2 diabetes prevalence, low insulin secretion, and high insulin resistance, high IR, which I told you before, because the body composition is adverse. There's a high liver fat, there's a high intramuscular fat, and low muscle mass. The Masala study partially the diabetes is more likely to have severe hyperglycemia subtype corrected by beta cell dysfunction. Here we have a poor beta cell D deficiency is poor, beta cell mass is low, and there's a low body weight, and there's a high incidence of subclinical atherosclerosis also. In PubMed, when we have seen the macrovascular complications South Asian, there were coronary heart disease severities, again, we are at the receiving end. So now, why the South Asian population is different than Caucasians? We have a bad body composition. We have a high fat, high obesity. We have a high intravisceral fat, number one. It has been seen that the observation that the stress level in South Asian populations is 10 or 15% higher than the counterparts. We have a high stress level in our system. Number three, we have a more sedentary habits. We have a more sitting hours, and sitting is like a smoking. So we do not understand the importance of the lifestyle, and we have a long hours of sitting, and sitting is again bad, which again increases insulin resistance. Smoking, there's an increase in young generation smoking incidence. Then eating pattern is getting different. That time they used to have a dinner by 7 o'clock, used to get up early in the morning, 4:30, 5 o'clock, but always having a walking modest activities, and we have used to have thick, we have used raw wheat, or we have a more primarily the wheat is a recent generation in the crop formation carbs, but it was a jaw was very significantly present in the summer hours, summer's days, and bajra was in the winter days. So it was a little we are used to have a raw food that time. We never had a very high finished food like we are what we're getting today is a wheat is a highly finished, very power form. And the timing in millions is shifting. It is almost 2.3 hours shifted. We are late risers. We leave our bed around 7:30, 8 o'clock in the morning and sleep around 1 a.m. in the night. The timing of meal has been shifted almost by 2.3 hours. And the selection of the food again is a bad. We don't go to the kitchen. We don't generally cook. We order through this Swiggy or different applications, Japto and all different applications or Zomato. So, and get a rich food, which is primarily is a bad nutrient food. The low quality food, high fat incidence, and then high fat of Azimoto salt and different strictures, which is giving you more food allergies and high triglyceride incidence. Again, coming to the beta cell mass, as I already told you before, we have a poor beta cell mass, and the mass is low, and D differentiation is less, and the beta cells are more dysfunctional. The sleep like cycle, if you don't go to a good time of sleep properly, you don't take a proper sleep, you take a distant sleep. You take blue light diabetes. Now in the night, the evening, we go on a digital, we are on a laptop, we are on mobiles, doing lots of applications there. And it's a blue light diabetes, or what we call is a digital diabetes. So the point is this, that if we are not taking good amount of sleep, if we're not having a bad or disturbed sleep, then the point is the stress level is high, cortisol level is high, and we have done having a more incidence of coronary incidences. We have a more incidence of the CV strokes, and we have likely have a high triglycerides and lipid levels. Starvation hypothesis, starvation in the middle of plenty, if we seen, then there's a difference in the Caucasian and the South Asian. We have a high cortisol response to stress. Cortisol levels are almost close to the same, but we have a high level of cortisol when we come across some stress, and again, resulting in high blood pressure. We have hardly hypertension, we have poor hypertension, we have brittle hypertension, and then we have seen there's an early onset of diabetes almost a decade before than the counterparts. Then what I've been talking as a fat. The intravisceral fat, the fat, intra-organ fat, intra-liver fat in between organs, and there's a fat in muscle mass, intramuscular fat is a high. And then we have a low brown fat. The brown fat is almost 15 to 18% less than Caucasians. Then we have a low muscle mass, almost 18 to 25% low muscle mass. We have a primary sarcopenic body coming to the counterparts. We have a bad dyslipidemia. We have a high triglyceride levels, and these are triglycerides are killing your system. Early onset of complications, we have seen that the early onset of complications, coronary incidences, which is in presence of heart failure, which is a primarily hyperglycemia, and then coincidence because of mitochondrial dysfunction, and there's a kidney, which is what we call it CRM, that is cardiac, renal, metabolic, where we involve the fat, we have involved the liver, we have involved things, have a bad CRM. Now there have been a lot of discussions nowadays with CRM. Then we have seen high insulin resistance. The insulin resistance is almost 20 to 28% high in South Asian population. And then lower basal metabolic rate. I've been observing this data and seeing that why we do not lose body weight to the extent of the exercise we are doing that with counterparts. Then we found that our lower basal metabolic rate, which is a primary required to drive your body, even when you're resting, is low. If the ratio is there's a 1.2, we have a less basal metabolic rate than counterparts. This is a fat. And now if you see compare the Caucasians, they're almost the same age is 30, 35. The BMI is almost 23 in Asian Indians and 24 in Caucasians. Then waist hip ratio is almost close to the same. That's 0.79, 0.75. But the abdominal fat is 296. The abdominal fat, what we're calling as the intravisceral fat, is 296 when Caucasian is only 203. And the visceral fat is 82%. What happened? A visceral fat is almost two times. So you just see more than two times. There's a 39, there's a 82. And what we have subcutaneous fat, again, we have a little on the higher side, which is intramuscular fat. The biggest problem here is glucose disposable rate. We have almost 60% of the glucose disposal rate than Caucasians. Glucose disposal rate, we burn calories little on a lesser side than our counterparts. It's a pictorial depiction of subcutaneous fat and the visceral fat. You can just see. This is the Caucasian structure. Here is a South Asian structure. We have a lot of fat, intraorgan fat, which is hidden fat. There's a cross-sectional view of abdomen, intra-abdominal or visceral fat surrounding the internal organs. Has a what is fine liver, the kidneys. There's a lot of fat all around, a lot of fat. Visceral fat obesity. Here's a visceral fat obesity. Here the pancreas cells, the beta cells, and now there has been studies that recently seen in the PubMed. We are failing beta cell adaptation in South Asian families with a high risk of type 2 diabetes. Then South Asian individuals, rapid beta cell deterioration, the beta cell life is less. The deteriorate might occur under insulin resistant conditions because of high insulin resistance. So what happens? Beta cell exhausts fast. Beta cell releases more and more insulin, more insulin, and the beta cell gets exhausted, and there is a rapid decline. And as the early insulin response, there's an early insulin response correlates with the strongly with the both glucose disposal and late insulin response alters in a beta cell dynamics. We give explanation of early onset of type 2 diabetes. Here we see there's early and late insulin secretion rates. There's average, there's a low it's early and late insulin secretion than Caucasians, and there's rapid decline with their early and late DI between normal glucose tolerances. Here's a relationship with the insulin sensitivity, early phase beta cell function, and the glucose disposal. Here in South Asian, here is South Asian, you see here South Asian, here's a kind of Caucasians. If when they see here in triangle is NGT, the square is fasting glucose, and it is in circle is type 2 diabetes. So we have find that we are more distributed. There's an early incidence of type 2 diabetes. So once a patient is a diabetic comes to a physician, the physician is really confused. We have so many drugs. We have so many. We have to prevent diabetes. His kidneys. We have to look for his heart. We have to look for the CV incidences, and almost is confused. So 12 to 15 drugs are there. He or she gets confused what to do. So RSSDI, let me congratulate RSSDI, R. Chawla, Indian Journal of Endocrinology in 2020. They came out the circle. They made a circle. And here the spine is a lifestyle management. The basic spine here in the lifestyle management, what does it mean? It means that life spine is a basic concept. It has to be always been there before you start any drug. Now, then you will see there is a metformin. Metformin is always to be associated. It works at the mitochondrial levels, decreasing the peripheral resistance, increasing the peripheral glucose uptake. So metformin should always be associated. Then we have A, B, C, D, E, F, G, H. We have all alphabets here, A, B, C, D, E, G, F, H, which gives you an idea of what to do, what not to do. Let's all come to this. So here is A is H, B is a BMI, And one C for CKD. Here is age, there's a BMI, high BMI, then there's CKD, if there's a high incidence of low EHFR or poor ACR, then it is a CKD. What we have to drugs, look for the drug SGLT2 or D4 with associated insulin. Now, if we have a duration of diabetes, increasing duration of diabetes, here is a duration. And if it's a high duration of diabetes lasting more than a decade, so we should always start with the SGLT2 and D4 because SGLT2 inhibitors, there's work in heart failure, which is they work in the mitochondrial, they improve mitochondrial dysfunction, better function of mitochondrial, and there's increased ketone body metabolism, which is a primary responsible in improving the heart failure. Then they work by decreasing mitochondrial apoptosis. Then DPP4, what the DPP4 does, they have a decreases beta cell apoptosis. And in my study, there is a beta cell reversal or beta cell increased mass, but it is not an experiment study. So coming with the duration, now then established CVD, this is E. E is established CVD, low CVD risk or established CVD risk. Now coming to finance, because in Indian, most of the people, our population, have to bear the cost of treatment, the cost of the comorbidities, and in OPD, these are not being covered by insurance people. So finance is because it's a lifelong medicine. Whosoever gets a diabetes associated with it, they have to be there on many of the medications, even the statins or the aspirin in case of coronary or the clopidogrel. Then coming to G, G is a glycemic status. If you have a high A1C, I told you before, it is sulfonylurea. It's the most important drug. The G is glycemic status. So if you have a high A1C, we have to look for these molecules. Then we have AGI, alpha glucosidase inhibitor, and many other more drugs in pipeline. So the basic is if what we are starting with a discussion of pharmacotherapy molecules, metformin, 95 FDA approved. Though it came in 1980, but did get an approval in 1995, got an FDA approval. And then this is a work, decrease new glucogenesis, glucose absorption, and there's a glucose intake at the peripheral levels, decrease insulin resistance. Sulfonylurea in 1950, we had a type 1 diabetes, chlorpropamide, disulfamide, tolazamide, very potent, but very strong and gives hypoglycemia. So what the sulfonylurea has done, it is a decreased release of insulin, decreased production of glucose, increased number of insulin receptors, and so on. Acarbose, beautiful drug in 1995 FDA approval. It is an anti-diabetes in diabetes. It is a generic sold in Europe and China as a glucobay and is a starch blocker. It works by inhibiting alpha glucosidase, intestinal enzyme that releases glucose from large carbohydrates. So if we are the postprandial hypoglycemia, acarbose is a good molecule to be associated. And mechanism is carbohydrate absorption, depends on postprandial hyperglycemia. A1C is 0.5 to 1% reduction. Whenever you take a meal, take a carbos. So almost you're taking 3 times a meal. There's 3 times the carbos. But there's a lot of flatulence. Is there. Then glitazones, where we had a rosiglitazone, pioglitazone, which is with FDA approval. And they enhance insulin sensitivity in muscle, adipose tissue, inhibit hepatic glucogenesis, perhaps stabilize beta cell dysfunction. The safety and efficacy is good, but the point is this: they associate increased edema, increased weight, and heart failure associated. So these are the PPR gamma regulate adipocyte production, secretion of fatty acids, and glucose metabolism, resulting in increased insulin sensitivity in adipose tissue. So pioglitazone, rosiglitazone, two molecules, and this is the way how does DP4 inhibitors work? Once you take a food, there's a release of GLP-1, and what the DP4 enzyme inhibitors are there, increasing the level of GLP. GLP-1 level is just lasting few minutes only. But if you give DP4 inhibitor, another good molecule, and there's an increase in GLP-1, which stimulates insulin secretion, decreases glucagon. And I already told you there's an increased insulin secretion, decreased glucagon release, and there's a glucose control is improved with DPO inhibitors. And we have a lot of drugs. First of all, the sitagliptin was approved by FDA in 2006. And later on, we had linagliptin, alogliptin, vildagliptin. And the beauty of the linagliptin is that even in renal failure, you can continue drugs, whatever the EGFR is there, even in less than 30, you don't have to change the dose of gliptin. Now, coming to
मैं
the
नंबर देता हूँ, दिनेश
LDL,
से पूछिए एक बार भी
it's
नंबर
a
देते हैं तो
remarkable. It's a significant, it has changed the whole management system in type 2 diabetes, and especially the lovely molecule, even preferred by the nephrologists, even in diabetes, without diabetes. It has been loved by cardiologists, even in absence of diabetes. So initially it was a Jardians or a present in 2014. It has been recently has come up in generic forms. And then we had a DAPA. Cana was first to come, but Cana had a several complications, and it was hold for a time. Then we had a DAPA and empagliflozins. The starting with DAPA is 5 milligram, and in INPA is 10 milligram. The min dose is a 10 or 25 milligram of EMPA. And the EMPA can be continued till 20 ml. Here it is a little disturbed, but you cannot start, but you can start at less than 25 ml EGFR, but can be continued up to if your patient is on, can continue till 20 EGFR. It is one of the beautiful, the advantage of this drug
पहली
is
बार ही हुआ
they
था
decrease the renal
है ना वो खोलो देखें जरा
progression of
हाँ
failure. There is a
थ्रोट भी
definite
कंजेस्ट हो रहा है
improvement in
लेकिन
the
अभी
renal failure studies, and that
थ्रोट
is the
कंजेस्ट हो रहा
beauty
है
that it has been
दर्द है गले में
loved
क्या
by the
थोड़ा
nephrologist, and it has been FDA approved in
यहाँ दर्द थोड़ी है
2023, even in absence of diabetes by the nephrologist. And same thing has been approved because it works beautifully in heart failure. So the cardiologists love this molecule, the first molecule in presence of heart failure, even in absence of type 2 diabetes. So DAPA has a low BG, reduces CV risk, and you have to read heart failure and a slow renal disease. There is a definite improvement in microalbuminuria and macroalbuminuria, very proven values. Now, GLP-1 RAs, they are receptor agonists, beautiful, miracle drug, miracle molecule, and it works beautifully. And the most important that one, they're very potent, less hypoglycemic, and they have a beauty is that they work in obesity. The mechanism of working is a brain level. They increase the receptors. The patient increase the satiety levels. They make the patient not to eat much. Number one, at the tongue receptors, they alter the sweet sensors, the sweet receptors, the tongue one, and patient feels less sweet, less liking for the sweets, and then it works. So at the gastric delaying, so definitely there's a gastric delaying is there, but that is again been maybe taken as a side effect. If not been patient counseled well, patient may discontinue over a period of time because of the price factor, number one. Number two is because of the gastric delaying, saying that डॉक्टर साहब बहुत एसिडिटी करती है पेट भरा रहता है but dear friends it is a gastric delaying is very important and gastric delaying the patient doesn't feel to eat again and again and we have many of the molecules for the GLP-1 RAs. We have a lixisenatide, liraglutide did come before. We have a Victoza as a trade name in the market, but there were injectables. Then we had a semaglutide, like an Ozempic, which again been injectable, given though weekly injections. And now we have a beautiful oral semaglutide also coming as a Ribelsis. It's a beautiful molecule starting with 3 milligram, 7 milligram, then 14 milligram. And we do have a Biodata is Exenite to start with before, which was given injectable forms, and they're definitely beautiful working in renal disorders. They slowed down the renal failure, they slowed down the falling EGFR, they
सबसे
slowed
पहले जाके
down
ये
the
लेनी है
poor ACR.
ये
And
ये
the latest
उसके
molecule which
आधा
has
घंटे
been
बाद से फिर बाकी
in
सब
the market is
ये
a
वाली शाम को ले लेनी है ये
tirzepatide,
तो
which
हमें
is
तो एक अभी ले
GLP-1,
लेना
GLP-1,
आधा
is
घंटे
both
बाद एक रात को ले लेना
all the
अब
two
ये वाली
molecules, which is as a jab bound primarily for the obesity, Monzero for
तुरंत
diabetes. In India, it is a
उसके
Monzero
बाद
that is
में
working.
ये
And this Monzero is given
आधा
even in
घंटे
absence of diabetes,
हाँ
primarily
ये
approved
वाली
for
शाम को 6 बजे
obesity.
और ये
And
शाम
it
को
is
7
seen that over a period, it means a person may
5
lose
डेज
from
ये
16 to 22 kg
ये
weight.
5 डेज ये 3 डेज
Beautiful, lovely drugs and
और
primarily
बिल्कुल अभी
approved
सिंपल
for
खाना खाना
obesity also. So we have recently come
उनका
up
भी
as a
नहीं है और
Wegovy
लेकिन
also injectable form for obesity. In the final screening, all adults in South Asian population without the respector should be screened
दवा
at
भी
the age of
उससे जा
35,
थोड़ी है
not age of,
गंदन थोड़ी
and the screening should be done by fasting glucose levels for undiagnosed diabetes. Metformin remains the first line
थोड़ी इतना
agent of the
लिखनी है
glucose lowering type 2 diabetes. Insulin is now recommended only for those patients with type 2
करा ले
diabetes who require reduction
करा ले
more than
करा ले
2%
राहुल
to risk population.
नहीं
So
करा
back again
ठीक
to
रहेगा अभी करा के शाम को
RSSDI.
बता
Looking at the South Asian population, looking if we have
कोई
early
दिक्कत नहीं
onset
आएगी
of
चिंता मत करिए
diabetes,
करा के दिखा
looking
देना
have an early onset of comorbidities, looking at the we have a bad diabetes, high incidence of hypoglycemia. This RSSDI works beautifully for the physicians, and we the physician should understand, and we physicians should adopt RSDI wheel in our clinics, in our OPD, and should try to understand the beauty and the importance of the lifestyle management. So here comes the age, or I told you before, patient-centric approach, duration of diabetes, cognitive hypoglycemia, social factor, patient adherence, lifestyle management, which is the core. Whatever the molecule take, whatever the treatment to take, if you are not managing lifestyle, the things are failing. So managing nutritional therapy primarily for diabetes, which we have tailored plans, low glycemic index foods. We do have physical activity plans. There's a behavioral support and weight management support. The medical nutrition therapy stands in it everywhere. It is defined as a nutrition-based treatment provided by registered dietitian. The nutrition diagnosis are therapeutic and counseling services. So the goal of MNT is normal or near normal glucose levels, lipid levels, and blood pressure. We have a DASH diabetes program also where which lowers down the blood pressure also. And then we have a pyramids also, the food pyramid. The food pyramid is we have to take least is that here is a fat. Fat are to be least taken, fat, oil, fried stuff at the minimum at the least. Or probably if you want to take a week, it should be once or twice in a week, and the oil level should be almost per capita is less than 100 milligram in a week trial. Maybe a little, maybe recently says if you have bad dyslipidemia, maybe only 50 grams in a month, in a week time. Then there are substitutes to the meat, then the milk, and then we have as much as high vegetables, the green vegetables, the vegetables, and the fruits. And then the flour, we have a multigrain, we have a high bajra, or we have a high in this of jawar, and there's a lot of ragi combinations. The food list, this is a beautiful food list, which are the starch and the bread, the food and the milk, more carbs, vegetables, meat, so on. If you see the activity plan, its activity is we have one pyramid here, and this pyramid says the inactivity should be least. It should be least. Many of the time it is said that if you are sitting for a long hours, almost 15 minutes, take a 5 minutes walk. Keep going and then sit down again. Keep working again at 20 minutes time. Go for 5 to 10 minutes walk. So the strength and balance, because Indian diabetic people have a low muscle mass, have a low muscle mass, and as the age advances, the muscle mass decreases. So we should have a strength training program also. And the strength training program as with the yoga, tai chi, strength training, body weight exercises. And then This is a resistance exercise. Resistance exercise increases your muscle mass, while aerobic gives you muscle strengthening. And there's a endurance. They give you endurance, which are to be 150 300 minutes of moderate intensity, or there's a 75 to 150 minutes vigorous intensity in a week time. So it could be like a walking, jogging, swimming, basketball, or having many of the active aerobic outdoor games also. Then we will love to have a cycle, as now there's a lot of fashion today's in the cycling. We should do I love gardening also. We should, because gardening gives you beautiful scenic views in a house. You can have indoor gardens also, and then we should clean our house. We should not be much dependent on your housemates. So they make a little difference. Now, if we see there's a comparison in aerobic exercise and resistance exercises is here the muscle mass is there, the skeletal muscle. They all work on skeletal muscle. So what is it is an oxidative stress. Here there's a muscle protein synthesis and myogenic organism program is there. And the combined effects is that there's a high angiogenesis if you're taking aerobic exercises. And if there's a mitochondrial dynamics are changed, there's an improved function of mitochondria, less mitochondrial apoptosis is there, decreased pro-inflammatory markers, and there's improved oxygen extraction, there's a sub maximal energy efficiency is increased. And here, if you do a resistance exercise, what happens? There's ribosome biogenesis. There's a ribosome biogenesis, and then there is a myofibril hypertrophy, and there is a decrease in insulin resistance. So their point is this: the resistance exercise should be done twice in a week, while almost aerobic exercise should be done 4 to 5 in a week. They are symbiotic, they add to each other. These are the different types of aerobic exercise: running, jumping, jump boxing, light yoga, basketball, stretching, and then playing catches or the badminton. So there are many types of exercise. A physical activity recommendation for healthy adults, 18 to 65. There's a moderate intensity aerobic exercise, 30 minutes per day, 5 days in a week, like at least 150 minutes. Aim for at least 75 per minute when you want to have vigorous exercises. And then muscle strengthening, as I told you, 2 days per a week is a minimum. We can have a Tai Chi, yoga, Pilates, very popular nowadays. We can have stretch muscles also. So meditation is a definitely very important value in management of type 2 diabetes, because it is a hypertension that kills you fast. Diabetes, hypertension is globe in globe. They go all along. And for the we have South Asian populations, a high cortisol level to stress level. There's a high cortisol level. So once you go for meditation, control your stress, control your anxiety, control your anger, will make certainly a difference. And to how the meditation helps, because time is coming short, we have a better immune system function, better oxygen consumption, clarity of mind, thoughts. Just hold on, be all alone, think yourself, concentrate. You will understand many of the puzzles. You will have an answer to many of the puzzles. And there is a vagus nerve stimulation, as what happens recently. There's a new concept is coming, the vagus nerve, and vagus nerve. A lot of discussion about the vagus nerve, which slows down the heart rate, the deep breathing. Adrenaline glands produces less cortisol, and the improved stimulate parasympathetic nerve. These all gives you meditation is a good quality of life. A meditation decreases your blood pressure by 5 to 8 millimeter of mercury, depending on the depth of the meditation, the sincerity of the meditation. And what the yoga does, yoga increases your flexibility. Yoga increases your stretchability and body strength. Feeling of wellness. Once when you do, you feel very light, as if body has become very feather touch. The positive attitude, the energy levels are high, good memory, and better concentration. Because in all the competitive events, it has been said, do yoga, do meditation, improve your concentration. And what does do? It reduces anxiety, it reduces stress, depression, tension, weight, blood pressure, then it is the sugar levels. So the glycemic beta glycemic is all better, improved, not improved your dyslipidemias, Then tension in muscles, the muscles get fatigued, and the pain joints. At the age of 45, you are finding there's a lot of pain joints. जैसे गर्दन में दर्द होता है, कमर में दर्द होता है, घुटनों में दर्द होता है, क्या करूं, डायबिटीज ने मेरे शरीर को गला दिया. But definitely, they have a beautiful workup on this. So how the losing weight makes a reversal of diabetes? Initially, we were talking of decreasing glycemic index, hyperglycemia. Then when came, no, it is not on a hyperglycemia. It was cholesterol values also. It was a blood pressure also. It was obesity also. There are many of the factors we try to control. Now we can think that you can reverse diabetes, but not reverse exactly. The point is you can make your diabetes in remission. You can remain in diabetes remission till you without drugs. And how the diabetes remission can be placed by cutting down your fat levels. There's an increased fat in the liver and the pancreas. Drastic loss of fat will make, and it was deduced from the study that when you decreases your weight, there is better glycemic control, there's a better blood pressure control, there's a better intra-organ fat, and at the same time, there's a better A1C reduction is better. And the step one, low calorie diet. Step two, step the food and ongoing start with weight loss. And the massive finding, once when you lose your weight, things start getting reversed. Massive weight reduction is not needed, but look, you don't have to require a lot of weight reduction. What a modest weight reduction is required. And you have to have for that is the structured life. The follow SLIM. SLIM is a structured life intervention methods. SLIM, structured life intervention methods, focusing on your diet. You should eat by your brain. You should not eat by your stomach. You have a mindful eating, as Mr. Narendra Modi has said. Our old father of India, Mr. Gandhi, late Mahatma Gandhi also said, one should eat mindful eating. One should eat a less chapati than what is required. And you should additionally start with your diet from the fruits, the green vegetables, followed by your carbs. And absolutely, there's no place for the sugar. So, thick to thin. Weight loss and diabetes is reversal program. It is a remission program. So the pharmacotherapies we had understood, we have gone through it. We have known the drug of choice, efficacy, cost, patient adherence. Monitoring is very important. And how to monitor and what to monitor? Your monitor is A1C every 3 to 6 months. Fasting and post-prandial glucose level should also be monitored. Your A1C may be same, but definitely glucose levels, intra-day glucose levels, intra-week glucose levels, they keep on changing. There's a high fluctuating blood sugar levels, but with the same BMI. So always watch your fasting and post-prandial glucose levels. Weight and BMI should also be looked for. Better look for always serum uric acid, renal functions, EGFR, and ACR. Very important, always look for microalbuminuria also. Very important, and renal function EGFR. Target values are A1C should be less than 7 for individuals. Their blood pressure should be less than 130 by 80. LDH should be less than 70. If highly sick people or we have a with a bad history, it should be less than 55 LDL. The complication and screening for complication, we should do a retinopathy, yearly examination or 3 yearly examination of retinopathy, nephropathy, as I already told you, ACR, EGFR. Neuropathy should always look for yearly assessment. Foot care is significant. We all know that the non-traumatic amputation, foot amputation, is post-traumatic, non-traumatic amputation is high. Primary the causes diabetes, neuropathies, and peripheral vascular disease. Comorbidities, hypertension should always look for. If you have a cardiovascular disease or CKD, use of SGLT2 inhibitors and GLP-1. Education is very important. One should always be understand and learn education and empowerment, very important. We should have ongoing diabetes education program, self-monitoring. My sincere congratulations to Dr. G.D. Ramchandani for having a approved center for diabetic educators. Hypoglycemia recognition is very important. adherence to medication, sick days rules are there, foot care practices very significantly important. So the FDA has approved this GLP-1, a lot of GLP-1s are there. I already told you oral semaglutide. Now the recently is come as orglipron or forglipron is coming out oral drug which is significantly has a much value in obesity and the management of diabetes, the ABC of diabetes, A1C, blood pressure, and cholesterol. S is stop smoking. Now, forget this chart. You should come and see management of dirty diabetes is through RSSDI wheel. RSSDI wheel is significant, important. Everyone, clinicians, and should be a part and parcel of the clinic chamber. Should be always put on there. There's display and should always given weight. Now, the last and most important is CBT. Cognitive behavioral therapy is always very important. Don't jump upon pharmacotherapy. Once the moment you see there's a hypertriglycemia, high A1C, or bad cholesterol, don't jump upon writing a medicine. Always try to make the things cognitive, behavioral therapy, CBT. If you have do good counseling, if you make the people to understand what it can mean to tomorrow, if you are not taking the what it could be a tomorrow for you, you should always make them wiseful. Let them decide. You don't decide. Let them decide. Let the patient have his own decision and then make his behaviors, make his diet plan, make his lifestyle, give him the thoughts that he has to live a good quality of life. Give him a feeling that if he's good, he will have a better feeling. He will feel young. And there's a behavior, feeling, thoughts. They have a serious interplay and has a very proven value because we have seen in last days a young suicidal rates are there. Thank you. Mahatma Gandhi emphasis on a simple plant-based diet and practice in nature cure aligned with modern recommendations for managing and preventing diabetes. While he may not have directly addressed diabetes, I'll tell you, Mahatma Gandhi was himself diabetic. His holistic approach to health and his lifestyle choices have a valuable lessons for promoting well-being and preventing life. Our respected Prime Minister Narendra Modi, importance of mindful eating. You should not eat by gut. One should never eat by gut, but you should have eat by your brain. Tackling health issues head on. When promoting brown rice or raising awareness about the raising of diabetes obesity rates, always encourage people to take better care of themselves. Thank you. Thank you very much. I will stop here, sir.
Thank you very much, Dr. Pradyum Sharma. It was such a nicely taken up lecture, and I hope that all the students and delegates and all the doctors who have attended this program must have taken the cues from the guidelines and from the advices on the lifestyle and the stress relaxation and the physical activity recommendations. And we continue with the short certificate course, and next week we'll be covering on probably the infections in diabetes, right? So that again is a very important part. And I once again congratulate and thank Dr. Pratim Sharma, who is a very senior person, who's been practicing for almost more than 4 decades. And I've seen the journey of management of diabetes across the decades. So it was very nice to hear his experiences. Thank you very much.
Thank you. Thank you.
Yeah.
Thank you. Thank you for supporting me.
All right.